At-home brain stimulation is arriving in your clinic. The long-term safety data is not there yet. Transcranial direct current stimulation, or TDCS, is a non-invasive neuromodulation technique. It delivers a weak, constant electrical current through scalp electrodes to modulate the excitability of cortical neurons. A nodal stimulation is thought to enhance excitability. Cathedral is thought to inhibit it. The current is sub-threshold. It does not trigger action potentials. It biases the resting membrane potential. The established in-office option is transcranial magnetic stimulation, or TMS. It is FDA cleared for major depressive disorder and for several other indications. Sessions are 20 to 40 minutes, delivered by a trained technician, typically 5 days a week for 4 to 6 weeks. Treatment is supervised. Adverse events are logged, and the patient is in a clinical environment. The risk profile is well characterized. For short-term TDCS, within established safety parameters, sessions up to 40 minutes, current up to 4 milliamps, total charge under 7.2 coulombs, no serious adverse events or irreversible injuries have been reported. The most common side effects are mild and reversible: skin redness, itching, and a tingling or burning sensation under the electrodes. The 2017 and 2025 international safety guidelines are consistent on this point. Supervised at-home TDCS is feasible. A 2020 guide in brain stimulation laid out how to do it with remote oversight. Since then, large sham-controlled trials have shown safety and tolerability in supervised at-home settings for major depression, including a 2024 JAMA Psychiatry trial, a 2025 Nature Medicine trial, and a 2025 American Journal of Psychiatry spaced protocol. The supervision is the key word. Remote oversight, scheduled check-ins, logged sessions. Here is what the evidence does not yet cover. Most clinical trials of TDCS run up to 30 days. A few longer trials exist: 6 months in Alzheimer's, 24 weeks in ALS, 6,779 remotely supervised sessions analyzed in 2022. But the evidence base for years of unsupervised, consumer-grade at-home use is essentially absent. That is the central concern in a 2026 Frontiers perspective on long-term TDCS use. Even in supervised trials, harms have occurred. A 2023 home TDCS trial for depression was prematurely terminated because of skin burns under the electrodes. A 2025 spaced protocol 5 sessions per day for 10 days reported mild irritative contact dermatitis in 64% of participants, and there are documented cases of mania or hypomania induction, a known risk for any antidepressant class intervention. Dose response in TDCS is not linear. 2 related theoretical concerns. First, metaplasticity, the brain's homeostatic compensation. Repeated input biases cortical excitability in one direction, and the brain can compensate in the opposite. Effects observed in a single session may diminish, plateau, or even reverse with chronic use. Whether this happens with chronic at-home TDCS is untested. Second, competitive plasticity. Enhancing one region can suppress functionally related regions. Both are theoretical but plausible risks. The absence of evidence is not the evidence of absence. Devices are widely available for direct-to-consumer purchase. Many are marketed for cognitive enhancement, not treatment. Some are self-assembled from published schematics. The 2024 European Medical Device Regulation reclassification has been described in invited commentary as an existential threat to research and treatment access. The core problem is the absence of systematic data collection on long-term outcomes in unsupervised users. As at-home neuromodulation becomes more common, the risk-benefit balance is more defensible for patients with a clinical condition than for healthy users pursuing cognitive enhancement. The device does not replace step care escalation to in-clinic TMS, ketamine or esketamine, or ECT clinicians who understand the framework ask, document, screen for harm, encourage reporting, will be better equipped to counsel patients and make appropriate clinical decisions. That is the framework the 2026 perspective proposes, and it is the framework you can use in your next encounter. For questions or episode ideas, drop them below and subscribe for more psychopharmacology breakdowns. Educational purposes only, not a substitute for clinical judgment.